whenever you see FTI Catalyst dashboard, obviously that's you can brand it yourself with whatever you want to call it. But we've got metrics or dashboard pages under financial, operational, quality, and staffing. So we'll jump into financial first. So that main landing page also serves as a navigation tool. You can just jump right to the box you click on, and remember under financial we had 6 buttons. Those correspond, transposed to the 6 tabs we have going across the top here. This particular dashboard page we're looking at here is profitability by product line. When you land on a particular page by default, it shows you a certain window of time. I think I'm looking at a 4-month window or whatever. But whenever we set this up for you, we can customize it. You may say, I want to see, you may say, for instance, I've got a lag of 2 months, and so I want to see months 3 through 6, whatever the case may be. We can set up that defaulting in terms of how, when you land on a page, what the default window is, as well as any other prompts you may want to see at the top of the screen. So these particular prompts control the whole page. I'm looking at a single product line, which is orthopedic surgical, but you can add, remove to your heart's content. What we've got, I'll start walking you through the data, but essentially on every dashboard page you have that flexibility at the top in terms of what the time range is, what hospitals you want to see results for, product lines, but any other attributes you want to put up there that may limit the results that are shown on the page, that's fully customizable. So we're looking at here a scatter plot of profitability by product line. So I've got the margin, which is payments minus direct costs, going on the bottom axis here. Going up on the y-axis, I have total charges. So each individual dot represents an individual patient. So the colors, and I have got a legend over here if I scroll over, but the purple is Hospital A, which is, we'll call it FTI East. The orange is Hospital B, which we'll call FTI West. So the color is just an added layer that allows me to segment the different hospitals from each other if I want to see for the same product line what the profitability is, for instance. So I'm not necessarily concerned about the cluster here. So each individual point is a patient, as I indicated, but I'm more so concerned about the outliers. So this particular patient, very profitable over here. This particular patient, less so over here. You can see my margin on my x-axis is about negative $9,000 on that particular case. So let's say, for instance, I wanted to understand who that patient was, why I had $72,000 in charges, but I still lost about $9,000 or so dollars. Clicking on that individual dot gives me some information, obviously. So I've got the hospital, where they were discharged from, who the patient was, when they were admitted, when they were discharged. I can see they were in-house about 8 days, what their DRG was, total charges, allowances, bad debt, expected payments, direct costs. So I can see my costs exceed my payments here, right? So that's sort of the gist of that scatter plot, really, and I can hit the back button, jump back to it. Now, even though we're showing it to you in terms of a scatter plot, we also build in some flexibility where you can see it in different aggregations. So let's say, for instance, you didn't want to see it by individual patients in a scatter plot. You can simply toggle and see it. So this is a summary by month of my surgical orthopedic patients. And I have the number of cases by month, the sum of the actual payments for those 179 cases, for instance, what the direct costs were, and what that margin was. So it segments it. At the top, I have the East Hospital. At the bottom, I have the West Hospital. I also can toggle that to see it by individual DRG. So this particular product line is made up of individual DRGs. That's how we define the product line. So here are the individual DRGs, and I can see which ones I had a lot of volume for, what the profit was on each of those, and it's, again, segmented by hospital at the top there. So everything I've just showed you is really just 1/4 of one page of one dashboard. So continuing on, if I just shift over to the right a bit, I have a trend over time by month I'm looking at of the profitability for my orthopedic surgical line, again, broken out by month. Again, if I wanted to see it by pay period or whatever the alternate time frames you may want to see it in is, see that data in, you can see it that way as well. Below that, so that was the dollars trended over time. Below that, I have the number of cases trended over time. And again, I toggled it to pay period, so this particular chart is also looking at it on a pay period basis. Well, the purple bar represents hospital A, the orange bar represents hospital B. If you have, say, 7 hospitals, whatever the case may be, you'll have a bar or a line for each of those. And if you recall, going down to the bottom left-hand corner of the dashboard page, if you recall, I had these individual dots that represented the patients. And in some cases, I may want to see, well, who were those patients and what were the circumstances around them in terms of who the physician was, what their length of stay was, those cases that I lost a lot of money on, right? So you remember I had clicked on an individual patient. Here I have my worst 10 patients in terms of profitability. So it's sorted in ascending order, so I have my negatives at the top here. So I can see who those patients were. I can see what the DRG was. If, for instance, I wanted to see who my best patients were, who my most profitable patients were, I simply just click on that column heading, and now I have the inverse look of it. Now, with this particular tool set, all of this is downloadable to Excel. You can download the entire dashboard page to a PDF, all of that. But the intent really is, the way I've designed this is to ensure that your users don't have to leave the tool set directly. They can do the exploration directly on the dashboard page. And that's, again, another reason why we allow you to specify the date ranges, individual hospitals if you want, one or more product lines. If you want to see activity for a certain physician, you can limit it to that particular physician using the prompt for the MD. So that's sort of the objective of the profitability by product line, is to show it in aggregate, whether it's trended over time, whether it's by pay period, by total cases, or the aggregate of the profitability over to the right, but also at the individual patient level, so you can understand what those outliers are and what's driving them. Any questions on that?
Nope.
Okay. So the next dashboard page, naturally, physicians can be a driver of your profitability depending on what types of supplies they use, that sort of stuff. So length of stay, how well they're managing length of stay. So what we're looking at here is profitability by MD. And I call it an accountable MD because what I'm doing here is, if the DRG is of a medical DRG nature, I'm using the attending physician. If it's a surgical DRG, I'm using the surgeon. So the sort of combination of the two represents an accountable MD. So for your surgical cases, again, you'll see the surgeon listed. For the medical cases, like general medicine, for instance, pneumonia, you'll see the attending physician. So similar to a scatter plot, we've got a graph here that shows my profitability on the bottom axis, total charges on the y-axis. But what I'm seeing here is a bubble for each physician. So the size of the bubble represents the number of cases. So you see, as I mouse over this particular bubble, I see the number 81. 81 is Gene Crabtree. Okay. So I can see the individual physicians in a tabular fashion over to the right that had the most cases. And again, I'm looking at orthopedic surgical, but you can toggle it for any particular DRG. But for orthopedic surgical, for whatever the desired date range is, I'm looking at the number of cases and the profitability at the MD level. If I scroll down a bit, I've got, instead of the individual physicians being represented by a bubble, I have physician groups. So if you have a group of physicians, we roll those up together, and so you can see the impact at the physician group level as opposed to the individual physicians that make up a group. So that's sort of what we're doing on this particular page. And naturally, again, we have the ability to drill down to the detail below that. So that one bubble represented physician group 28. I click the bubble, and now I can see the individual cases that comprise that one bubble that was on the prior screen there. Same concept for the profitability by MD. So I clicked on the red bubble there with the 81 cases, so now I have 81 records for Gene Crabtree. And so I can see the individual patients that make up that one bubble. So the intent really is to show you the view from, say, 2,000 feet, and you can say, okay, well, what's going on over here? And then investigate further. So that's the gist of the profitability by MD. It's similar to the product line, but more of a physician perspective to it. Any questions on that?
Nope.
Okay. The next page is payer mix. And so let's say, for instance, for orthopedic surgical, my cases are increasing over a period of time. It's not necessarily just the fact that my cases are increasing, but the case mix or the case weight often has implications in terms of your margin on those cases. So if I'm looking at orthopedic cases and my volume has gone up 10%, but when I examine that volume more closely, I have not so many hips, but I just have a lot more femur procedures, for instance, which have a lower case weight. Naturally, that's going to be a less profitable situation for me than, say, if they were hip replacements. And so that's why we take a look at, on the financial dashboard, the payer mix and the case mix. And so first I'll talk about the payer mix. This is a spider chart that shows each of the types of payers on the outer rim of that little web there. The closer it is to the outer rim, the more profitable the average case is in that particular for that particular payer. So I can see, for instance, on the self-pay for my self-pay patients, I only net about $1,300 on my orthopedic surgical cases, whereas on the Medicaid side, I seem to be doing much better for these orthopedic surgical cases. Now, this is an average per case. So if I look over in the middle there, I can see that even though I'm doing very well for my Medicaid cases, I only had 9 of them, right? So naturally, you can see on a per case basis where you tend to be more profitable, but you have to take into context as well the number of cases as well. And so if we scroll over to the right, we have the number of cases, the average margin per case, and then the total margin. So by far, I make the most money on my orthopedic surgical cases for HMO type patients, and I can see that they average about $2,700 per case, and I had about 336 of them for the time period in question. So that's the payer mix page. Case mix is a similar concept in that we have the different payers going on the outside here. And I can look at my case mix or my case weight. And so the further it further towards the edge of that spider graph it is, the higher the average case weight per case is, and naturally that typically has ramifications on what you'll be reimbursed by that payer. And so again, I have by financial class the number of cases, the APR DRG case weight, as well as the MS DRG case weight. So we show them both there. We also have a state DRG case weight if you're inclined to use that as well. So that's essentially, in a tabular fashion, a summary for that time period, again, for that product line. And then a graph by individual payer of the number of cases, which is represented by the pink dot here, and graphed on the right-hand side relative to the case weight. And so the purple is the DRG case weight, the blue is the MS DRG case weight. And so I can see on a Medicaid side, for instance, it's readily apparent that I have a higher case weight, and if you recall from the prior dashboard page, I have a higher reimbursement for these cases. But you can see from the pink dot that I only had 9 of those cases, which confirms what I saw on my other dashboard page. So not only do we look at the payer mix to determine how a particular product line is comprised, we also look at the case weight or the case mix because that naturally drives your reimbursement rate and thus your profitability per case. Any questions on that? Okay. One of one of the feeds we take in are is your charge detail feed. And so we take in all the granularity of what the supplies were that were used, your room charges, your visit charges, all of that type of activity. And what comes along with that charge feed is a post date and a date of service. And so one of the things we look at is that lag between when the service was rendered, the service date on the charge, relative to when the charge was actually posted. And so naturally, for a number of reasons, you want to minimize that gap between when the service was rendered and when the charge was actually posted. So this particular dashboard page looks at all the charges posted in a particular area. And here I'm looking at FTI West, for instance. So for the 6-month period, there were about 165,000 or so charges posted. 91% of them were posted in 4 days or less, right? So then I'm also seeing over to the right what that breakout is by individual department. So which departments had a high rate and which ones had a low. So I'm sorting it from worst to best. So I can see my emergency department, my OBS unit, they tend to have a low percentage in terms of posted within 4 days, and that's due to some regards the need to abstract those cases. But I can see continuing down which particular departments have an issue in terms of posting their charges in a timely basis. And so that's sort of the intent of this. And not only are we saying, okay, for the observation unit, what was their percentage of charges posted with a delay, but I can drill down to that charge level detail. So I can understand, okay, for instance, this particular charge took 7 days to post. The service was rendered on March 31st, didn't get posted until April 7th. So you have the ability, as we saw on other dashboard pages, to drill down to that level of detail. So if you're the manager of this particular department, you're a click away from understanding why you have a lag in the charges, which charges in particular, is it all happening on a particular day, and oh, was that the day my secretary who posts those charges was out? So you can sort of understand better what's going on in terms of the charges that are being posted. Any questions on that?
Dan, on that one, can you break out between inpatient and outpatient units?
Yeah. So you have two options. When you set up there's a table that we're going to provide you that is a department master table. Okay. So it depends on how you want to define inpatient versus outpatient. Do you want to look at the time that the charge was posted at the individual patient, or do you want to say, regardless of whether the patient was admitted or not, if they were on nursing unit 5 South, I treat that as an inpatient unit because all the patients that flow through there, tend to be inpatients. So it depends on how you want to define inpatient, but yes, either at the charge level we capture the visit type. So at the time Dan Gerena, for instance, was in the emergency department, I was a type E, for instance, or an outpatient, or wherever you categorize you categorize it at the patient level, but you can also define that at the individual department level. So, you can treat everything that happens on your nursing units as an inpatient unit, and so you can add a prompt here if you wanted to. For one option you have is to add a prompt at the top to segment inpatient from outpatient, but have the default be both, for instance. So does that answer what you're looking for?
Yes, thanks.
Okay. Any other questions? So I'll jump to the operational dashboard. So from an operational perspective, there are a couple of things we want to monitor, one of which naturally is discharges. So the first dashboard page under operational takes a look at my discharge summary. So I'm looking at a 6-month window. Again, you can default that to the most recently completed month. You can default it to year-to-date, whatever your desire is. But in this case, I'm looking at a 6-month window. I'm looking at the inpatient discharges. And I'm looking at them aggregated by financial class. So I can see that Blue Cross, for instance, represents almost a third of my total discharges in the 6-month window. So on the left-hand side, I'm looking at it in terms of parts of a whole. I'm looking for that 6-month window, what each of these individual financial classes represent as parts of the entire whole. Over to the right-hand side, though, I'm looking in terms of a trend over time. So as opposed to a window, I can see movement by month on the right-hand side to see whether or not I'm going up or down in terms of the number of commercial patients versus Medicare, et cetera. This is segmented by hospital. So at the top I have West, below that I have East. If, for instance, I want to understand what these 64 no-fault cases were, again, I'm a click away from doing that and drilling over to the patient-level detail from there. By default, we're summarizing it by financial class, but let's say, for instance, you wanted to see it by gender, or you wanted to see it by the patient's language, their primary language. That's probably not a good example because the majority of it's going to be English in this case. Or severity of illness, for instance, so your APR severity of illness. So we've built this in a way where you can see a summary of your discharges by a number of different attributes. And again, none of this is set in stone. If you say, for instance, I want to load eye color, and I want eye color to be one of the attributes I have in this drop-down, for instance, whatever attribute you want, as long as it's captured in the data model, it literally would take 2 minutes to add an additional field or to remove a field. So it's fully customizable. We're just by default showing you this particular list. Okay. Any questions? I'm going on to the length of stay dashboard page. And so on the left-hand side, I have discharge length of stay. Okay. So for that 6-month period, by hospital, what my length of stay was by month. So I'm showing it in 2 ways here. I'm showing it in a tabular fashion here, and then below that in a graph. So the bars represent the length of stay, and the line represents the number of cases for that particular period. So let's say, for instance, I look at this and I say, wow, FTI East, I have a high length of stay, 7.05 in January, for instance. Again, as you would expect, you have the ability to drill down to the patient detail and evaluate it from there. Let me go back real quick. You also have the ability to click an individual hospital, and now instead of jumping down to the patient level detail, I have the ability to see it. I'm going from the 10,000-foot view. Instead of going to the 1-foot view of the patient level detail, I'm going to, say, the 100-foot view, which is by discharging department. So I can see the length of stay by individual department by month, and then naturally I can drill down to the individual patients that make those numbers up from there. So the intent of the left-hand side is to evaluate length of stay and understand if it's increasing or decreasing over time. You also have flexibility in terms of looking at it by product line. So how many cardiac medical patients did I have in January of 2010, and what is that relative to the rest of the year, and how has the length of stay been moving on a monthly basis in terms of that product line. Now over to the right, we take a little different view of the information. So even though you may have discharged 100 patients yesterday, let's say, for instance, you have 500 still in-house, right? So this particular, on the right-hand side, we look at the patients who are still in-house. So what are those number of cases? What's the average in terms of length of stay? And this is old stale data, so that's why it increments every day. Your numbers would be a lot more reasonable than that. And then what the maximum in-house length of stay is, right? So I can quickly see those 262 patients and take a look and see why they're in-house, who they are, who the physicians are. And here's it's sorted from highest stay to lowest stay. So I can see, for instance, what those longest stays were. Or if I sort it the other way, I can look at the folks who were just admitted yesterday, for instance. And then over to the, still on the right-hand side, but down below that, I'm looking at the number of cases in-house by physician, and I can see those 262 patients summarized by physician, but there are a number of different ways in which we can examine that information. So instead, if I wanted to see the most popular admission diagnoses for those inpatients, those in-house patients, I can toggle it quickly and look at it in that manner. So this particular page, again, looks at length of stay from both a discharge and an in-house length of stay perspective. Any questions? I shall continue on. Discharge management. So one of the things that's important in terms of efficiency is if you think in terms of how you schedule your OR cases. The majority of folks are scheduled for morning surgeries, and you have a number of patients who are scheduled to be discharged that same day. So one of the things you want to do is align your OR surgery schedule with the actual discharges that occur. So when it becomes time to admit those surgical patients who you need to admit, you actually have a bed to place them in. So this particular page in terms of discharge management looks at, by hour of day, the number of patients discharged. So I can see for this particular hospital, the majority of patients stick around for lunch and get discharged in the 1 p.m. hour, for instance. Naturally, I want to shift that forward earlier in the day so I have beds freed up in terms of capacity so I can admit my OR patients to that. And typically your ED is going to be busiest in the morning as well. So if you have to admit patients there from that source as well, you want those inpatient beds freed up. So this takes a look at your ability to discharge patients by hour of day, and naturally you want that to be as early as possible. So I can see, for instance, that 44% of my patients are discharged in the 1 p.m. or earlier hour. So if I want to look at 10 a.m., for instance, only 7% of my patients are discharged prior to the end of 10 a.m. So I probably want to improve that particular metric there. Over on the right-hand side, we're just drawing a line in the sand and saying, okay, forget by hour of day. Let me see prior to 11 a.m. and after 11 a.m. By individual nursing unit. And so I can see that some nursing units, the majority of the patients, stick around till after 11 a.m. So on Unit 7, for instance, in the West Hospital, about a full 94.5% of patients stick around until after 11 a.m. before being discharged. So this is a more granular look at this information, so I can see by nursing unit how we're doing in terms of different types of units, and then you can set objectives naturally to improve that and use this discharge management dashboard to track your progress there. As far as admission sources go, so again, I have a 6-month window, and I'm looking at where this is summarized by admit source, where my patients are coming from. So I can see that 50% of my patients are admitted from the ED. Okay, so when I look at my inpatients. And over to the right is a graphical representation of that, so I can see the number of cases and the percentage represented in the blue there. So it's just a Pareto chart there. But naturally, you have the ability to look at this information in other ways. So for instance, if I want to see it by nursing unit, I can see that these top 10 nursing units represent about 53% of my total inpatients that are admitted, and I can see that graphically that it's a pretty even distribution, which you'd probably expect unless you have a couple of really big nursing units. So even though by default we're showing it by admitting source, you can look at the information in a number of ways, for instance, by referring MD, and see if you're keeping track of that particular attribute, what patients that are being admitted are being driven by which particular referring MDs. So I can see Dr. Hurley here for this time period was responsible for about 100 or so admissions. Any questions on that? Now I'm going to jump to the ED and OR page. So I mentioned earlier we're capturing activity at the charge level. This information on the left-hand side is looking at OR level cases from my charge detail, and it's trending it by month. So I can see the segmentation by level visit in my operating room by month. So it's a good way to track volume, essentially, of OR cases by looking at the level, the number of patients and their respective level minutes. And then below that, I'm looking at, for those particular patients in those minutes, I've got a summary by surgeon, for instance, by procedure, of those OR minutes, so I can see who the biggest users are in terms of those minutes. You know, I can see a summary by payer, et cetera. So it allows me to profile and understand what's flowing through my operating room based on the charge level activity that we're feeding into it. And then over to the right, we have the ED level visits. So the ORs and the EDs are a big driver of your volume and a big driver of your admissions. So on the right-hand side, we chose to take a look at the emergency department level visits trended by month. And then below there again, for those same patients, we're bringing in other attributes like severity of illness, zip code, MDC, financial class, et cetera, so you can profile the volume that's flowing through your emergency departments and your operating rooms. Any questions?
Nope.
Okay. Last dashboard page on the operational dashboard is looking at room charges. So again, I mentioned we were capturing all of your charge level activity. Here we have an individual dot for each day of the year, okay, for an individual unit. This allows me to see the variability in terms of how many room charges post. So how many patients, let's say your room charge is posted midnight, for instance. How many patients on average did you have at midnight for the last year, whatever? I'm actually looking at a 6-month window here. For that 6-month window, on average I had 27 patients, but I can see there's a great deal of variability around that. The red squares actually represent a Monday, so every 7th dot is a red square. So this allows me to just get some context and see relative to the rest of the week how Mondays are doing, for instance. So this gives me a good idea in terms of an individual unit level, what's going on, and so I have it naturally for all of my units, wherever I have inpatient beds. And then over to the right, a trend, and this is showing a trend by pay period of that volume, and I can segment that naturally by hospital. So this is an average for the 14-day period. So on the average day in pay period, let's call it pay period 2, for instance, I had 239 patients in the West Hospital. It's just taking the sum of the total patient days dividing by 14, so I can get to a pay period, an average per day by pay period. Next we'll toggle over to the quality dashboard. So from a quality perspective, we look at things like mortality rate. So at the individual patient level, we're going to have a disposition. One of those dispositions is going to either say death, expired, et cetera. So what we're doing is that's going to be our numerator. Our denominator are our total cases. And so I'm just computing a non-risk adjusted mortality rate here, essentially, and then breaking that out by month over time, so I can see how that fluctuates. So the bar represents that mortality rate by month for whatever date range you specify, and the line represents the raw number of expirations from a patient perspective. Over in the middle here, we segment the same information by age category. So based on the date of birth relative to the admission date, we're grouping patients into 8 or so categories, and I'm looking at the number of patients I had relative to the number of deaths for that patient population and computing a mortality rate. So naturally, as you would expect, it does get higher as your average patient age gets older. And then this is just an average age of admission for this segment, so about 86 years old. So if I wanted to understand, for instance, who are the 14 people who died in a certain age range, for instance, I'm just a click away to getting to that information. And that is just the same information, just graphically represented, so I can see an inclining mortality rate as the patient groups get older. Over to the right, we have a summary of the expirations. And so I can see that 54% of my patients were severity of illness 4. But I also can see that about 2.4% were severity of illness 1. So I can take a look at who those individual patients with the severity of illness 1 who expired were by simply just clicking on that pie slice and understanding who the physician was, what the DRG was, all of those types of attributes, what their risk of mortality was, etc. So that is the mortality dashboard. Next, we take a look at readmissions. So we define a readmission as an individual patient who, upon discharge, comes back within 30 days. Okay. Now, we give you some flexibility here. If you want to say, for instance, 7-day readmissions, you have the ability to just toggle that in the page and rerun the information. So for a 6-month window here, I'm looking at a particular, my readmission rate. So over on the left-hand side, I have the total number of cases in that 6-month period, and of those, how many readmissions did I have? And so I'm just computing a readmission rate there, a 30-day readmission rate in total, and then below it broken out by hospital. This here is a histogram of the days since the last admission. So for the 380 patients who came back within 30 days, I can see that 54 of them came back the same day. I can see that 19 of them came back a day after the original discharge. And so you see sort of a trend of that the majority of your patients are coming back very soon in that 30-day window. And you can understand that better by looking at those patients. And so here is a trend by month of your 30-day readmissions. So I had in January, I had 20, went down to 17, et cetera. And then over to the right-hand side, we have a summary of those readmissions by product line. So I can look at, for instance, cardiac surgical angio. And for cardiac, we're breaking out into two. So here, let's talk about a readmission. Let's step back a second. For a readmitted patient, they had the DRG that was for the first discharge, and then they have a DRG on their second discharge. So this is, the prior is their first discharge, and the current is their second discharge. So folks who were discharged with surgical angioplasty, there were 13 of them that were previously discharged, and this is a view of what their original product line was when you look at their original DRG. So I can see, for instance, if it had orthopedic, for instance, as one of them, that's probably not something that's related to why they were readmitted the second time. But I can see in this case the angio and the cardiac medical ones, they're probably related to the second admission for that patient. And naturally I can drill down and further investigate those folks. And so I can see, for instance, each record represents a readmission. So I can see what their current length of stay was on the most recent admission, what their prior length of stay was. So they were here 2 days, discharged, and then 5 days later, admitted for another day, right? So now I can get to understanding what they were here for, who their physician was on both encounters, that sort of information. So that's the readmissions dashboard. Any questions on that?
Hey, Dan?
Yep.
How much of this is coming from the billing system versus the decision support system?
Well, when you think about a readmission, the only thing you don't really need anything unless you're trying to compute the impact, for instance, of the readmissions. But in terms of identifying the readmissions, It's all demographic information. So for instance, if you give me a table of 100 patients and you, let's say, Carl, you have a medical record number that's unique to the individual, all my logic is doing is saying, okay, find this unique, the unique matches. Okay, Carl was here 3 times in a 30-day period, and then I'm doing the math between each of those. You know, let's say it's a 6-month period. Of the 3 times Carl was here, how many of them were within 30 days of each other? So there's really no, it really doesn't necessitate any financial information to compute the readmission rate itself. But you may say at some point, you know, I want to understand what the total charges were or some other, you know, what the profit margin was, because now I'm starting to get denied for the readmission, that sort of thing. But to identify the readmits themselves, it really doesn't require any financial information. I'm just looking for the same medical record number in a certain window of time. Does that answer it?
So it comes from the billing system?
It depends on where you want to pull your patient demographic information. So yeah, if we're going to pull your demographic info from the billing system, then yes.
Okay.
It depends on
the most dynamic. That'll be more dynamic than the decision support information.
Yeah, then in that case, you're probably going to want to pull it from the billing system because you'll get updated information. So let's say we pull from the billing system all of the patients on a daily basis. You don't have to wait 30 days to see your readmission rate for April, right? As soon as your feed of April discharges is loaded on May 1st, for instance, I'll be able to see what my readmission rate is, right? Because I'm going to have both discharges represented in the historical data, as opposed to if you pull it from your decision support data, you know, it's only going to be as timely as your refresh interval for that type of data. So if you only refresh that, say, biweekly, you wouldn't know till, say, May 15th what your April readmission rate was. You know what I mean?
Okay. No, I just want to make sure I understand it.
Yeah. So it all depends on where you want to source the data from in terms of the timeliness. So for stuff that's really not, even though readmissions has a financial implication, the identification of those readmits is agnostic of whether or not you made money on the patient. So there's no need to wait until, you know, you cost it out, for instance.
Dan.
Yep.
Dan, are you able to break this out by payer? Because now Medicare has a readmission, really a penalty.
Right. Yes.
For 3 categories.
Right. When we look at the patient level detail, we capture a number of attributes. You know, what hospital did it occur in, who is the physician. Let me see if I have it here. But one of the attributes we capture at the patient level is the financial class. So let's say, for instance, you know, I neglected to, which I did, I neglected to include the financial class in here. The financial class is captured, so it's simply a matter of, you know, going in the report, clicking it, and now we have the financial class there. And so you can either capture the, let's say for instance, there were 2 different financial classes, one on the first discharge, one on the second. The first, let's say it was Medicare, the second was self-pay or whatever. You know, I'm making up a scenario. So you have both attributes in terms of the current and the prior financial class available to you. So even though, you know, we're showing a high-level view of readmissions at sort of the 10,000-foot level from a organizational perspective, it's simple enough to, in this particular table here, to instead of saying MD, I can add a third option here that says by financial class or payer, right? So then you would see Medicare, Medicaid, et cetera, in the summary table here. So we're capturing the attribute. It literally would take 4 minutes to swap it in as an option. So next time your users log in, you'll see a third option here that says summary by prior financial class, for instance, and then you'll just see that summary there when they select that option. Does that make sense?
Yes. And then 2 other things, which I think you answered the question, but we have an ACO, Accountable Care Organization.
Yep.
We have around 120 odd physicians, and I think they want to keep track of their readmits.
Yes.
Can you cluster a bunch of physicians and with that, Rupa?
Well, yeah. So here's what I would suggest for that. One of the before I made reference to a department master table, we also have a physician master table. So what you'd want to do in that physician master table is have an attribute that, let's say you call it whatever you want. Let's say you call it ACO, right? Put a flag yes or no, right? That would then be exposed as an attribute that you can add to not only this report, but you can add it to any, you can add it to your mortality dashboard. You can add it to complications. So as long as you track that attribute, say in your physician master table, that is in the predefined data model, you can report anything by it. So you're not limited to just readmissions or mortality. If you want to see profitability, for instance, or volume by those ACO MDs, what you can do is you can add that attribute, that ACO, let's call it an ACO flag for simplicity. You can add that as an option here, or another option you have is at the top here where you have these prompts, you can add that ACO flag as an optional prompt. So if I wanted to see this page just for ACO physicians, I can set that to yes, hit the go button, and then now I'm looking at just a readmission dashboard or mortality dashboard for my ACO physicians directly, and then when I interact with this information, I can drill down to the individual ACO physician. Does that answer your question?
Yeah, and I got one other question, Butch.
Sure.
Is one of the attributes admission source?
Yes.
Because we also want to track and readmissions coming from nursing homes. Is that
yes.
one of the attributes? Okay.
Yes. Anything, and do you track, for instance, the specific nursing home?
I don't know.
Okay. Because let's say, for instance, you did, right? So you have an admission source, which you can summarize your mortalities by, you can summarize your readmissions by, you can summarize your profitability by. So, for instance, if you wanted to know, what my readmission rate is on orthopedic patients that were originally admitted from a nursing home, right? Very easy to do, assuming you have that data attribute. If you also know and capture in your registration process the individual specific facility of origin, like Jimmy Jones Nursing Home, that sort of thing, you can expose that in the reports too. So I can drill down I can look at and say, okay, I have a 10% readmission rate on admissions from skilled nursing facilities, and then drill down and say, okay, what are those that seem to be my issue in terms of individual facilities, and then go have a conversation with those types of facilities to say, what's going on here. So theoretically, in theory, we're starting with a predefined data model, right? But that predefined data model, you can add as many attributes as you want. Once it's implemented and installed, it's yours. So if you want to add body mass index, if you want to add individual origin in terms of facilities, you can add that and easily just go in here and modify that, any of these dashboards or reports, to include that as a summary attribute or a dashboard prompt attribute. Does that answer?
Yes, thank you.
Okay. Continuing on, we have a diagnosis and procedures dashboard. So one of the fact tables we're going to capture takes a look at the patient level. We have a primary diagnosis and a primary procedure. But for every patient, you can also have up to, say, 14 or so more secondary diagnoses and procedures. So we load that type of information into our predefined data model. And so you can see, for instance, we also give you a master table that lists all of those diagnosis codes and groups them into, say, diagnosis categories, okay? So I can look at all of the diagnoses that map to, say, urinary disease, and I can see by what that volume is in terms of primary and secondary diagnoses. So I have a lot of those types of patients, but the majority of them have it listed as a secondary diagnosis as opposed to the primary diagnosis. And then down here is just a summary by diagnosis category of your volume, and I can even get down to individual diagnosis codes within an individual diagnosis category. So under alcohol and drug, for instance, I can get down to very specific patients. So if I want to identify any patients who had a certain diagnosis code, I can simply toggle that, and there are my 5 patients. And was that diagnosis present on admission, yes or no? Okay. So very quickly we can, yes, go ahead.
A couple people have left. It's just Lee and I right now. I think we have the gist of what it can
Sure.
do. So I'm not sure where Pink Rose went.